Hello, everyone. Thank you for joining this panel. My name is Anis Benbrick. I'm the convener of this panel on evaluation in times of COVID-19 in the Global South. This is our fourth panel today. We have 3 papers today. Each panelist will have 20 minutes presentation and 5 minutes Q&A. If you have any question, please raise your hand or write your question in the chat box. So let's start with the first paper, Social Protection and Federalism in Times of COVID-19, the case of Brazil, with Mayara Albrecht. Mayara?
Yes, thank you very much. Can you hear me?
Yes.
So I'm going to share my screen. Can you see it?
Yes.
So my name is Nayara. I'm a postdoc researcher at the Federal University of São Carlos and a fellow of São Paulo Research Foundation. I'm from Brazil and I have a very strong Brazilian accent. So if you don't understand a word, please ask me later and I will explain. So my research project was about social policies and federalism in Brazil in times of COVID-19. The team is related to understand social policies, how social policies interact with federalism. So my main goal was to investigate the effects of the pandemic in change federative arrangements related to social protection. And my research questions was, has the pandemic altered the functioning of federalism in Brazil, or has it fortified some previous process of change? How do external shocks interact with internal rules? And how do intergovernmental relations affect policy performance? And all these questions were related in some way to the new institutionalist approach, which is very common in policy analysis and political science in general. So about the methodology, I employed a case study of Brazil. Brazil is a really interesting case because we have some institutional arrangements regarding federalism. So we have a federative system composed by 27 unities, subnational unities, and they have a very close relationship to the union, especially regarding the implementation of social policies. So the federative arrangements actually it varies with, it depends on the policy domain. So about social protection, we have a very cooperative federative arrangement because subnational unities are encouraged to cooperate with the union all the time, especially regarding implementation, the implementation of social policies. So we have these cooperative arrangements, and our main social program in Brazil is called Bolsa Família. Maybe you know it because it's a very, it's a widely known program. It's earned a lot of international prize, so it's very recognized in Brazil and abroad. And this program, it has some specific rules regarding cooperation between subnational unities and the federal government. And we have also some state policies which reproduce the design of Bolsa Família. They are very similar to Bolsa Família. But during COVID-19, the government approved a new social program, which was a temporary program, and it was an emergency aid, and it's a little bit different from Bolsa Família. So that's why I adopted this methodology. I try to compare Bolsa Família to state policies, especially the design of the programs. And I also compared Bolsa Família to this temporary emergency aid approved during the pandemic to tackle the economic and social effects of the pandemic. And I compared finally the federal aid to state emergency policies, because some states in Brazil also have approved their own emergency policies. So the methodology comprises a case study of Brazil because it's a really leading case about federalism. We have a federalist system which has its particularities. The arrangements vary according to the policy domain. I also employed a literature review and a documental research. So I analyzed a lot of documents regarding this national program and also state policy. And I try to investigate these aspects related to federalism, the jurisdictional centralization. I mean, by jurisdictional centralization, I mean the way laws are formulated, elaborated, and approved. So in Brazil, we have a very centralized system because the union is mainly responsible for formulating policies, whereas subnational units are mainly responsible for implementing. So I also tried to analyze fiscal arrangements because in Brazil we have also fiscal centralization. So the union is responsible for distributing resources, and this is very important, especially during the pandemic. Another relevant aspect in this analysis is party federalism, because we have a conflict between parties. In Brazil, we have a lot of parties, so like 30, and the national reality is a little bit different from municipal and state realities. Sometimes we have some cooperation between parties in the national level, and this kind of alliance is different in the municipal level. So that's why it's important to analyze also party federalism. And finally, the role of superior courts. I mean, especially the superior courts, which is responsible for analyze the accordance between laws and the constitution, especially because regarding federalism, most arrangements are established by our constitution. That's why this is a very important aspect too. So regarding theory, I adopted a new institutionalist approach because I try to investigate the role of formal and informal rules shaping human behavior. And by human behavior here, I focused on the behavior of subnational authorities and the federal government of Brazil. And I also explored some models of policy analysis because they investigate different factors which may result in institutional change. For example, COVID-19. In models of policy analysis, COVID-19 is considered as an external shock. So it brings some windows of opportunities to change policy. And we are going to see that it happened in Brazil in some way. So I also tried to explore the literature on varieties of federalism. And here I focus mainly on two models of federalism. One is the cooperative model, and the other one is the competitive one. So in a cooperative model of federalism, we have more cooperation between subnational unities and the federal government because they share responsibilities regarding to public policy. And on the other hand, in a competitive model, we have more competition between subnational units and the federal government because they have sometimes clear roles regarding public policy, and they have they have responsibilities regarding policy domains which provide competition between them. So in Brazil, we have 27 federative units. I mean, 27 what we call usually states. The constitutional test brings us a hybrid model because we have some competitive and also cooperative arrangements, and we have a jurisdictional and fiscal centralization. About social policies specifically, we have a lot of rules encouraging intergovernmental cooperation, especially because the union is responsible for distributing the resources, but municipalities and states, they have clear roles in implementing social policies. They are, for example, responsible for giving information to the union about beneficiaries. And this is very important to the implementation of the program, especially Bolsa Família, which is our main social program. So with COVID-19, a lot of states in Brazil implemented lockdown measures, which triggered several social and economic effects. The federal government had to approve an emergency aid. And this aid is a little bit different from Bolsa Família, because Bolsa Família is an aid to low-income families, but it requires some conditions, especially related to child healthcare and education. And in contrast, the federal emergency aid was an unconditional amount given to a broader list of beneficiaries. So it has no conditions. It's just an amount the government gives to low-income families and also informal workers. So formulation and implementation of policies were marked all this time by conflicts between the president and subnational authorities, I mean governors, and the superior court had to intervene. During the pandemic, President Bolsonaro has downplayed the disease, and he clearly opposed to lockdown measures, whereas governors and municipalities tried to implement these social distance measures. So that's why we had a strong conflict between the president and subnational authorities. And 21 of the 27 states implemented their own emergency aid with designs which were very similar to the federal policy. So it happened a little bit similar to Bolsa Família, because we have Bolsa Família, which is a federal program, and we have a lot of state programs which are similar to Bolsa Família. And this has to do especially with electoral incentives, because Bolsa Família is a factor people consider when they vote for politicians. So that's why electoral incentives play a key role in policy diversity. In this case, in diminishing policy diversity, we have less policy diversity because of electoral incentives. So with the emergency aid, it was a similar context, because the federal government implemented this federal emergency aid, and it has some impacts on the approval of the government. So states tried to implement their own emergency aid with designs that were very similar to the federal policy. And the consensus in the research literature is about Brazil, in this case, it was that there was a lack of coordination. So with Bolsa Família, we have clear rules about responsibilities of each unity for subnational unities and also the federal government. And in the case of the federal emergency aid, we didn't have clear roles established for unities, and we didn't have what we call pacts, because in Brazil we have this legal document called pacts between subnational unities and the federal government. And in Bolsa Família, they try to incentivize, to encourage this kind of pact between subnational, it's a kind of agreement between subnational unities and the federal government. And in the case of the federal emergency aid, they didn't have any incentive to cooperate about the institutional design of the policy. So here I summarize the main difference between Bolsa Família and the federal emergency aid. So Bolsa Família is a permanent social program. It has specific rules on intergovernmental cooperation. It provides economic incentives to states and municipalities to cooperate with the federal government, and it has also established the conditions related to child healthcare and education. In contrast, the federal emergency aid was a temporary aid, but they are already discussing if they will turn this a permanent policy because of its success in improved economic conditions and also because of electoral incentives. It has no specific rules on intergovernmental cooperation. it has unclear incentives for subnational unities to cooperate with the federal government, and it has no specific condition now. I mean, it's a broader list of beneficiaries. So the analysis, social policies in times of COVID-19, we maintain a low level of policy diversity, but implied less coordination, especially because of conflicts between the president and some national authorities. Electoral incentives continue to play a key role. That's why we had a low level of diversity. The pandemic contributed to change the scope of social policies because the federal emergency aid is different from Bolsa Familia. It has no conditions. So maybe this is a window of opportunity to change the design of our social policies from a conditional program to an unconditional one. And certain institutions and organizations acted as check and balances here, especially the higher court in Brazil, because it had to intervene because of the conflicts between the president and subnational authorities. So some scholars, they argue that the president was trying to install a conflictive federalism in Brazil because he had a very bad relationship with governors and other subnational authorities, but he couldn't change our institutional arrangements, and because institutions and some specific organizations acted as check and balances. Key points to advance this research agenda: the role of informal institutions. Most studies focus on formal rules, but we have a lot of informal institutions that may affect the policy process. And conclusions regarding changes in the federative arrangements of Brazil. As I said, some scholars are the president is trying to change the federative arrangements, but it requires deeper analysis of this new administration. Further questions to answer: will the next social policies reproduce the design of the emergency aid? This is a hypothesis because it opened a window of opportunity regarding social policies, but we have to see if they will change. They are already discussing this, and what are going to be the impacts of the pandemic on next elections, because it certainly contributed to have more people disapproving this government in Brazil. So I don't know, maybe some governors will run for president. We have a clear conflict between the president and the governor of the state of São Paulo, and maybe they will compete in next elections. So we have to see what are going to be the impacts of the pandemic on the next political outcomes. So that's it. Thank you all.
Thank you very much, Nayara, for your presentation. If you have any question, please raise your hand. I have a question for you, Nayara. Maybe you didn't cover it in the paper. So what is the role of a civil society organization in the development of social policy in Brazil? I had a short experience with the state of Paraná. I visited many times Brazil, and I worked with the federal minister of Brazil. I just forgot her name, but I think maybe your president changed her. This was in 2019, and I worked with the state of Paraná, and we've been in Curitiba many times. So I wonder, of course, as maybe this is true. I think there's a big difference between the different states, between Paraná and Sao Paulo. So do you think the civil society are involved somehow in the responses to COVID in terms of policy development or advocacy, or in the delivery of social assistance?
Yes, definitely. you know, we have some formal mechanism of social participation in Brazil. For example, we have public conferences, and we have also committees to listen civil society. But I guess this is decreasing in the last administration, because it's a totally different view from the previous one. So the previous government had this view of like social participation directly in policy formulation and implementation, but this new administration has a slightly different view of social participation. And at the same time, the pandemic is really hard because it requires social distance. So people are separate from each other. So that's it's a little bit difficult. It's an obstacle to social participation, because social participation requires people to be together in general. But we have some initiatives from civil society to try to help people during the pandemic. And we also have a very fragmented society, I must say, because some people agree with the president that the pandemic is not so bad. So some people were even against the vaccination. So the situation in Brazil is a little bit crazy right now.
Excellent. So from your experience and your point of view, if you want to conclude your chapter, do you think in times of COVID now, what is the effective model, being federal, state, or centralized health policy or social policy? For example, in Germany, it's also a federal country. However, the health policy and the social policy still at the state level. And this was an advantage in times of COVID, because states started early in responding to COVID in terms of social assistance or in vaccine. Yes, of course, there is a problem of coordination between the federal government and the state government. So do you think that it was an advantage for Brazil to have a federal, let's say, social policy design or social policy governance? What do you think?
Yes, it seems so. That's a very interesting question, because we were discussing this in another conference this year, because most scholars were really approving centralization before, because centralization, in the case of Brazil, centralization in the past helped to coordinate social policies. But during the pandemic, decentralization helped us to employ social distance and lockdown measures, because the president was really against it. But then the Superior Court intervened to say that the states and municipalities are also responsible for formulating this kind of policy. So mostly in Brazil, subnational authorities responded to the pandemic.
And my final question, how do you see the future of social policy, or let's say even the social contract in Brazil post-COVID?
I don't know, it's really hard. It's really hard.
Maybe what are the three top major reform you think the Brazilian government should start thinking post-COVID time?
I don't know, because Bolsa Familia has was transformed. It's like our benchmark. So it's a leading program in Brazil. I don't know if they will try to change, but at the same time, we have an administration which is really against the previous one. And Bolsa Familia was created by the previous government, the government of the Workers' Party, and that most population hate. So I think maybe they will try to approve some small change to social policies, but also because of the next elections, because they need these. This is an electoral incentive, because they need social policies to have best chances to run for president. So that's why I think maybe they will make a small change in social policies in Brazil. But it's really hard because our society now is really divided. So we have a very polarized society. So that's really hard to answer this question.
Was it effective? Do you see that Bolsa Familia was very effective in protecting families in Brazil, mostly in those vulnerable families who are left behind for many reasons? Brazil is a continent, 100 million, and very
Yes, definitely.
excellent.
It has helped a lot.
Excellent. Thank you very much for your presentation, Nayara. And I'm very happy to have you in my book. And hope to
Thank
see
you
you
very much.
soon. Thank you, Nayara. Now with our next speaker, let me check. Hafiz is here. Yeah, next speaker will be Hafiz. Sorry.
Yes, Hafiz is here.
I will give you the floor after Hafiz. So Hafiz, paper.
Yes, I am prepared. Please, can you assist to project my PowerPoint while I present? There is some technical glitches here.
So do you want me to share your presentation?
Yes, it's already on in your email.
Yeah, okay. I will just, so the Hafiz paper is on social protection and healthcare service in Africa, the collapse of a community-based healthcare insurance program in rural Nigeria. So we moved from Brazil, from a large country to another large in Africa, Nigeria. So let me share your presentation and then.
Okay, thank you very much.
Where is it?
Okay, thanks, Anis. I hope, can you all hear me?
Yes.
Yeah, this, good day, everyone. This presentation is based on a community-based health insurance carried out in Nigeria. Next slide, please. Yeah, next slide. Yes, thank you very much. As we are aware, in the most countries in Africa obtained independence in the 1960s and the 1970s. And this marked a period when most of these nations were trying to develop economically, technologically, and educationally across all sectors of the society. But unfortunately, in the 1980s, marked the wave of neoliberalism when social adjustment programs were rolled out, and these had a negative consequences for the provisioning of social services, including the healthcare sector. Then this marked the beginning of the challenge of healthcare services provisioning in Africa. Then the situation whereby people who had access to free healthcare services was replaced with prepayment system, whereby for you to access healthcare, you need to make payments. Otherwise, you won't be able to enjoy access to healthcare. And the underlying ideology for some of these policies are promoted by some scholars and some ideological bases that are neoliberal in nature. Next slide so that we can save some time. Next slide. Thank you. So as a result of these challenges, and the idea of coming up with community-based health insurance programs came up, whereby people make payments of certain amount of money. Then those who fall sick during the particular period would have access to care. If you do not fall sick, then you would have paid for the healthcare services provided to other members of society. And this model of healthcare system was adopted across many countries in Africa and also in Asia, mainly developing countries, including Nigeria. Then this also signifies the implementation of healthcare program in Nigeria, community-based health insurance program in Nigeria. This particular one that we are looking at was established in 2007, but it was not the first one that was established in Nigeria. But for this particular presentation, it is our main focus. The community-based health insurance program was established in rural communities in a state called Kwara in Nigeria. The program was proposed by a Dutch organization known as Dutch Health Insurance Fund. Then it delegated a foundation known as Pharmacist Foundation from the Netherlands to implement the program. Then the foundation also employed a local-based HMO known as IGEA Nigeria Limited. Then they collaborated with Kwara State government in order to roll out the health insurance program. Next slide. Yes, the program was supposed to be a donor subsidized health insurance program in order to provide access to health care for community members. Then as a result of this, the initial funding for the program was provided by the Dutch Health Insurance Fund. And they funded the program between 2007 and 2013. Then by the end of 2013, they expected the Kwara State government to start contributing financially to the maintenance and the funding of the program. Then they were expected to be taking a responsibility for financial responsibility for the program on a sliding scale, whereby they would be responsible to pay 60% of the finances, the financing requirement by 2014. They pay 70% in 2015, 80% in 2016. Then by 2018, perhaps they would take full ownership of the program while the international partner draws back. Next slide, please. Yeah, the program ran and it attracted so many awards from international organizations and local organizations at that time. But unfortunately, the program collapsed after 9 years. That is, it ran between 2007, then ended in 2006. Then this presentation, therefore, discusses the factors behind the collapse or stoppage of the program in Kwara State, Nigeria, in order for us to make necessary policy recommendations. First, to assess what was the reason for the stoppage of this program, to also examine whether this program was a viable one that could be recommended for other settings, then also to be able to identify the way forward in terms of the social policy implications of the program. Next, please. Yes, the conceptual framework that was adopted for the analysis of the data collected for this study is known as a Waltz and Gilson model, which is a model that is designed for analyzing healthcare system. The model has 4 dimensions. The first one allows you to understand the roles of each actors in the policy cycle. Also, it also gives you the opportunity to actually understand the policy content. It also gives you an understanding. It helps you to analyze and understand the context within which a policy was designed and implemented. It also gives you an understanding of the policy process. So that is why we adopted this model as a conceptual framework for policy for analyzing the study. Next slide. Yeah, methodology. The research site for the study was 11 rural communities were selected in the state where the program operated. Actually, the program operated in 43 healthcare facilities across many communities. So we selected 11 rural communities out of all these communities in order to get a rich data. Then the research design obtained was mixed method, whereby data were collected using both qualitative research instrument and quantitative research instrument. In all, 12 focus group discussions were conducted. 1,583 semi-structured questionnaires were designed and administered on those who enrolled in the program and those who did not enroll. 22 in-depth interviews were conducted among male and female community members that were enrolled in the program. Then 32 key informant interviews were conducted with community leaders, healthcare providers, policymakers, international partners, health maintenance organization officials, and a researcher who carried out a research on the study. Next. Then next, so that we can save time. Yes, the method of data analysis was SPSS, and Atlas TI was also used to aid the analysis of the qualitative data. Yeah, the respondents, the participants were asked about their perception. They were asked about reasons for the collapse of the program. Incidentally, majority of them said they were not aware. They didn't see any problem with the program that led anything. They were not able to identify any problem with the collapse of the program. But some of those who identified complained about counterpart funding. Some of them complained about poor treatment of healthcare providers. Some of them complained about poor management. Also, request for out-of-pocket payments after they have paid to enjoy benefit healthcare, to have access to healthcare for a whole year. When they get to the hospitals or the healthcare facilities, they would still be requested to make payments out of pocket, which is not acceptable. Then some people attributed the collapse of the program to funding challenge, while others had attributed it to bad governance. Those were the data generated through the quantitative instruments. Next slide, please. Yeah, the stoppage of based on the qualitative data obtained from the study, those that were asked, which include community leaders, community members, health maintenance organizations, government officials, and the healthcare providers and the researcher, all of them agreed that the main problem that led to the collapse of the program was non-payment of counterpart funds. You will remember that I said that the program came as out of a collaboration between the Kwara State government and the Dutch Health Insurance Fund. They were putting money together to fund the program. But at some point, the Kwara State government could not make payment for the program again. And they claimed that it was as a result of a cut in budgetary allocation from the federal government. That was the reason why they could not make payment. And as you can see, it was discovered that they were not paying, and they amassed backlog of payment to the tune of 300 million naira. So all of these participants that include community members, community leaders, health maintenance organization, government officials, they agreed that the reason for the collapse of the program was that the government was not playing its own part of providing fund to fund the program, that was the reason that led to the collapse of the program. However, the international partner was the only party that gave a separate reason from this one that the majority of the people chose. Next slide. Hello? Hello, can you hear me? Hello?
Yes, we hear you.
You can?
Yes.
You can hear me, please. Thank you. Yes, non-payment of counterpart funds on untenable view of the international partner. Like I said, it is only the international partner who denied, who declined or did not agree that the reason for the collapse of the program was lack of funding or funding challenge. Their excuse or the explanation they gave was that, for instance, by the year 2016, everything in the world was changing, and narrative changed that we needed to have universal health coverage. Everybody, everywhere, no matter the status or location, you must have access to quality healthcare. So the paradigm has to change, that community-based was strictly community-based. We needed to now have a statewide. So the CDHI began the journey of transitioning into a statewide health insurance. Their claim was that the program did not collapse because of non-payment of. Then they didn't give, the reason they gave was not tenable because, okay, sorry. The reason they gave was not tenable because
I think we lost Hafiz. He's disconnected.
hello, I'm there, I'm here. Can you hear me?
Yes.
Okay. Can I go ahead?
Yes, please.
Yes. Well, in order to round up on time, so that because of the challenges, then we were able to, the data, because you cannot claim that you want to express why you stopped. If you are expanding the program should continue to exist, then it's transition seamlessly without major glitch or stoppage. However, planned or they claimed to be extending was actually launched, but was not implemented. The program was not implemented. Then another reason found by the was changing government, because the governor that was in the political leadership at the time the program was.
There's a message in the chat box from Afis saying that he has poor connectivity and he would have loved to conclude, but you can go ahead.
Okay. Let's give him last chance, because we know. Hafiz, can you hear us? No, I think he has very bad connection. Okay, let's move to Yemen now. Yes, our next paper with Rabia Salah is the need for developing social protection and social welfare policy to respond effectively to COVID-19 shock in Yemen. Rabia, you are muted. Rabia, we can't hear you.
Hi. Do you hear me now?
Yes.
Yes.
Okay. Nice to see you, Dr. Anis and Nayara.
Thank you.
I would like to introduce my chapter, and I hope to receive good and constructive feedback from your side. I'm going to talk about the unique country, Yemen, that is facing catastrophic period. It has the worst humanitarian crisis, and it has the worst humanitarian crisis in the world, and we have the pandemic crisis besides. So it's a crisis within a crisis. So I focused in my research paper about the need for developing social protection policies to respond effectively to COVID-19 shock in Yemen. In my abstract, I focused mainly on supporting the country affected, the currently countries affected the social protection system and the health system by implementing new social reforms. and implementing like practical linkage between international humanitarian agencies and the national social protection agencies. Because in Yemen, we don't have a social protection system. We have acting social protection organization that is like the Social Fund for Development, and we have another organization that is the Social Welfare Fund supported by UNDP. So in this paper, I mainly focused on how it's important that the linkage between these agencies, both the funding, the international humanitarian funding agencies and the national agencies, so that they can intervene and prepare responsive to respond and mitigate the socio-economic consequences of COVID-19. So the results and vision in this research paper is based on dedication and accurate data analysis from credible resources to ensure providing like exceptional state-of-the-art information that may support agencies and decision makers at local and international levels. So I focused mainly on responsive protection policies, health interventions, lack of access to health services, communicable diseases. It's not only like we are facing COVID-19, we have also another outbreak, that is cholera outbreak. So in this research paper, we focused on the mainly affected population. It's not only the poor people or the general people in Yemen, that is almost 30 million point five. So we focus on the IDPs, and we have also refugees. So it was like a big catastrophic period. So according to the World Health Organization in the Yemen Situation Report in 2020, it says like 70.9 million are in need for healthcare and 24.3 million are in dire need for humanitarian assistance. So at the beginning of the COVID-19, there was no responses. There was no responses from both the governmental and from the international world. Even the medical Doctors Without Borders organizations was announcing that in Yemen, there was nothing at hand to respond to this shock. And we didn't have even oxygen cylinders to save the people. So there was a lot of respiratory cases and critical cases coming to Aden, that is the first target, Aden city, and we have like governmental hospital. And so Doctors Without Borders, they started to offer like their international assistance in this hospital to respond effectively to the COVID-19 shock. But the health system was already collapsed and there was no results. Thousands of people were recorded to die. And according to facts and figures at that period, it was saying like 24 million people need humanitarian assistance, according to the United Nations. The UN OCHA also announced that 13.5 million people face crisis level of food insecurity, and also 16.2 million in 2020 without action. 19.7 million people need healthcare, over 4 million internally displaced, over 2.25 million of children acutely malnourished, and more than 1 million pregnant and lactating women acutely malnourished. 17.8 million people lack access to safe water and sanitation. 149,000 refugees and asylum seekers are in Yemen. So there was also estimations that 2/3 of Yemenis, more than like 20 million people, are food insecure, and 10 million are at risk of famine. So it was catastrophic period. In my research paper, I focused on the methods that is actually highly recognized and implemented in intervene and also responding to any shocks. That is the strategy decision matrix and the delivery system decision matrix. So I was focusing on this matrix on how both the international and the national responses are, so that some actions are implemented and the lives of the people are saved, especially the refugees, the IDPs, the internally displaced people. And there were more internally displaced people because of the war. the war crisis, because in the front lines and in the clashes that is happening in Yemen everywhere, there are a lot of refugees who are living in camps, and they are at a high risk of spreading the COVID-19. And there were also IDPs who are displaced because of the COVID-19 in the city, because many economic shutdowns that pushed people to leave their homes and to leave these cities to go outside of the city looking for other opportunities. So in this regard, the government started to deal with international responses, starting with the World Bank. The World Bank announced 26.5 billion grant provided by International Development Association to the organizations acting in Yemen, especially the WHO, so that they can start to provide the ICU services, the laboratories, the isolation units, the intensive care units, and oxygen cylinders. So this was a good start, but delivering these services to Yemen was very restricted because of COVID-19. So many people were at risk of death, and we faced a lot of this, including in my neighborhood. So the World Health Organization worked alongside with the Doctors Without Borders. These two organizations were focusing on the health side, and the World Bank was also supporting them and providing them with funds. There was other initiatives, that is the Yemen Humanitarian Response Plan that started from June until December 2020. It is extended for the period of June 2020 to deliver action line services to control the spread of COVID-19. So there were some policies and acting policies in the site, including, for example, economic shutdowns. The local markets were closed, but there were some negative consequences, that many people lost their jobs, and many people they were in dire need for food assistance. And in Yemen, as you know, because it's a poor and humanitarian crisis country, there are like many people who are receiving cash assistance from the World from the World Food Program, that is like one of the international agencies intervening in this period. So there was a lot of actions in this period, but the consequences are still existing at the beginning with the COVID-19. But lately, in December, for example, 2020, the consequences were like, for example, mitigated, and the number of cases were controlled, and a lot of organizations from many countries supported Yemen, including like Arab countries, Saudi Arabia, Qatar, and many international countries. So UNDP was also one of the international agencies supporting Yemen, Islamic Bank for Development. These agencies were focusing actually not only on medical side, but on economic side, social side, and ensuring that the people reach like mass and media, ensuring that the people got like health promotion messages, so that, for example, they can know the social distance, they can control the COVID-19 while going back to schools, because no schools in Yemen were opened, and people were afraid from this COVID. And you know, as in Yemen, the people are very poor, they don't have anything in hand. And there was like big rumor in Yemen that going to the hospital, you will get like a mercy injection and you will not come back to your home. So the people were afraid of going to the hospitals. Even though the vaccine is coming to Yemen in this period, but it's not covering the whole Yemen. It started with the southern part of Yemen. But in the northern part of Yemen, the vaccine hasn't started yet, because the government that is controlling the northern part of Yemen does not agree about the vaccine, because they say and consider that the vaccine is actually bringing another virus. So culturally and the backgrounds and the political side is fighting this vaccine. But in the southern part of Yemen, that is under the control of the government, they started to provide the vaccine. So USAID was one of the organizations working with the national organizations to mitigate the COVID-19. So response by partners of Yemen Humanitarian Fund was an initiative supporting 20,000 people with many services, including the food, because some people, they were not allowed and they were not able to go to work, because some of them, they depend on mainly daily resources of food. They don't have, like, for example, for jobs, they don't have salaries, they don't have income, they don't have cash transfer. So they actually go to work day by day so that they get the income and come back to their family to feed their children and their families. So it was very catastrophic period. And the data, for example, were not clear, because many organizations, including the WFP, they needed information about the people who are in a dire need for food because they lost their job, and it was catastrophic period. People were not allowed to go. The teams of these organizations, they were not allowed to go like for further places because of COVID-19 restrictions. So collecting data was also very difficult. But now the people are able to get access and get support from, for example, WFP, by getting the food, and they come back to their normal works, because COVID-19 is already, like, you can say, like 90% of COVID-19 now in Yemen disappeared. And even like restrictions in the checkpoints, for example, there were like checkpoints in every entrance of every city of Yemen. They check every person if he has COVID-19 or not, if they have any symptoms of COVID-19, so that they can get quarantine period. Masks, they were not implemented in Yemen. It was not like restricted by the authorities, because we can say, like, in the northern side of Yemen, they don't consider COVID-19 as a disease. They say, no, there is no COVID-19, the government itself. But when they saw that the people are dying because of COVID-19, I was the translator of the Doctors Without Borders mission in the Zaid hospital, who were treating like the COVID-19 cases. And I was facing like these people who are saying like, oh, no COVID-19, nothing, don't believe. But the government themselves and the social securities, they started to believe in the COVID-19 when it was like, for example, when there was hundreds of people who are dying because of the symptoms, and the oxygen was not available. So they started to get the idea that the COVID-19 is around, and they started to use the mass and media to deliver the message for the people. So at national level, there was national responses, including like international initiative on COVID-19 in Yemen, that is supported by a highly recognized businessman in Yemen. It is Hayat Said Group. They started to support health facilities with personal protective equipment, with oxygen cylinders. They worked hand in hand with the UN. Social Fund for Development, it's the mainly acting social protection agency in Yemen, starting since 2015. So this agency faced multiple difficulties and challenges in this period, including the incapacity and preparedness to cover and respond to the vulnerable people's most basic needs, especially their need for social protection and human assistance. Because the Social Fund for Development, there was some suspended fund for this agency, because it is receiving mostly its fund not from the government itself, but it is under the control of the Ministry of Foreign Affairs. But it's not receiving any support from the government itself, but it's receiving its fund from international agencies. The international agencies, for example, if they support this Social Fund for Development, some of the programs were suspended. So they were not able, and they don't have anything at hand to deliver the services to the people. So Social Fund for Development is the main acting social security and social protection organization, but it does not have adequate resources, including the capable administrative side. One other thing is the Ministry of Planning and International Cooperation in Yemen. They worked hand in hand with international organizations. They worked in terms of making like networks and flexible coordination between the government of Yemen and the humanitarian assistance and agencies and the funding countries, so that they can deliver the services to the people and they can, like, for example, have both men and women find jobs. And these were one of the most important effective social protection interventions in Yemen, including some of the practical linkage intervention between like international humanitarian assistance agencies and between the social protection institutions in Yemen. So if this linkage is sustainable and is consistent, and it will deliver comprehensive services to the people will find that there is like continuous support. Because in this research paper, I found that, yeah, it was effective, the linkage, and delivering the services to the people was effective. And the people were, like, for example, receiving help. But actually, if this continue for future purposes, for the future, it will help this country. This is a low-income country. The people are poor. The health system is collapsed. The social protection system is not working. It's only an acting organization that is covering this work. So I can assure you that the humanitarian assistance and the close partnership with social protection agencies in Yemen can lead to significant reduction in harmful impacts of COVID-19. And now we are in the period of preparing for the post-COVID-19. But Yemen can't guarantee doing anything because the government is unable to do anything. I can say it like, in fact, Yemen can't do anything. Even if the government agencies are receiving some support, it will not be adequate to help the people. We have many international humanitarian organizations working in the ground. You can say, like, for example, more than 7 to 10 and more. These are like the big organizations. So if they work collaboratively with the social protection system in Yemen, we can find like effective social protection policies that can help the people to be able to respond to any future shocks. So in my chapter paper, it was highly recommending plans to develop the social protection system and welfare reforms in Yemen in the post-COVID-19 period, including first, like setting comprehensive recovery plans to avert any future shocks and mitigate the shock economic consequences and market restrictions, and strengthening comprehensive social protection system by continuously supporting from national and international levels, and implementing the social protection priorities and policies as mentioned by the Ministry of Planning and International Cooperations in Yemen Socio-Economic Update 2020. The second thing is designing readiness plans to respond to future shocks, because in Yemen we don't have like future readiness plans. Actually, I can't say only like COVID-19 was the only outbreak. Because of the war, water and sanitation problems were like everywhere, and cholera was arise. If you hear about Yemen, we have lost thousands of people and lives in Yemen because of cholera, because of diphtheria, because of measles, because of dengue fever. We have a lot of outbreaks in Yemen because of the humanitarian crisis. So we need also delivering long-lasting funding projects to the country is ineffective in Yemen because there is no long-lasting funding projects. Most of the projects that Yemen is receiving from international agencies are suspended, and they are like short periods. For example, they say, okay, until 2020 December, and then after that we wait until January 2022. And in this period, imagine there is a shock. Who can respond to it? Another point I'm recommending is developing the weak administrative capacity in the social protection institutions, including the social fund for development and also the social welfare fund. There is also a need for social protection alternative agencies in Yemen, more than 2 to 3, so that we can handle the rules of eradicating current social welfare and social protection gaps. And strengthening areas of social protection to tackle the COVID-19 crisis and developing preparedness and shock responsive policies. This is more important and should be set and should be like designed by international agencies and national social protection agencies. I hope that you got all my points in this paper, and because it's like a unique country to discuss about. And I was like working as a youth ambassador with with like international inclusive this social protection organization. I was attending online courses, and they were all astonished because of this. I wish that I can deliver this chapter and this research paper to international agencies so that they can make like a decision about how important is the linkage between international and national agencies in terms of supporting the social protection system and to deliver long-lasting and sustainable help to Yemen, because we don't have social protection system. And I am ready to receive any feedback from your side. Mostly welcome. And if you have any questions, I'm ready to answer.
Thank you very much, Rabia. First of all, I want to thank you for joining us from Iman during this difficult time. We pray for you. I mean, thank you very much for your paper, and I'm very happy to have you in my book.
Thanks a lot, my dear.
Social Protection in the Global South. So I have a question. I mean,
yes.
In the absence of the limited responses from government and international agencies, what is the role of the informal sector, more specifically, community, people, family, especially that Yemen is very known as tribal society. So what is the role of the informal sector in such circumstances? The community developed their own support system through family network, from friends and relatives, whether in Yemen or in foreign countries.
Yeah, this is very interesting question. Since the absence of the governmental like intervention in the communities, for example, we started to make networks, including doctors. We have the like one volunteer medical doctor who is ready like for consultation and who is ready just to welcome anybody at any time who is like complaining of COVID-19 symptoms. And in terms of responding to social consequences, we started like to have like a community engagement project that is like, for example, we share some money, we donate some money and make like a box so that we can give it to the most in basic needs people. But we can't guarantee that is like in all the governments of Yemen. But in terms of informal like intervention, you can say like 30% of which is successful, because many people are like you can say dependent on humanitarian assistance.
Thank you very much. Do you have any question for me?
Nayara, do you hear me?
Sorry, yes.
Hear you.
Yeah, I hear you, but I don't have any question. Your presentation was really complete. I'm just surprised about the humanitarian situation.
Thank you, Nayara. Thank you a lot.
I think if you have to, I think we still have time. Maybe we can get back Afiz to complete his presentation. Afiz?
Yes.
Thank you, Rabia. Thank you very much.
You're welcome, my dear. Thanks a lot. Thank you, Nayara.
Hello.
Hello.
Hello, I'm here. Okay.
I can hear you, Hafiz. This is your presentation.
Yeah. You want me to conclude the presentation?
Yeah, you can continue. I think we stopped here.
Okay, okay. Thank you very much. This should be on about the 15th slide or so. Okay. Yeah, yes. Yes, thank you. As I was explaining, I already identified that funding was the major factor that led to the collapse of the program. Also, I identified that the change in leadership of the states at that time also contributed to the collapse of the program. The leadership of the state as at the time the program was introduced was different from the leadership of the state as at the time the program stopped. So we can actually conclude that the interest in the program by the person who who collaborated with the foreign partner was higher than the interest the succeeding leadership had in the program. So as a result of that, they were not interested in the program and they were not giving the funding of the program the needed priority. So that also contributed to the reasons why the program collapsed. Then another factor was bad management. Bad management on the part of the state government, the Kwara state government, and also bad management on the part of the health maintenance organization that was commissioned to oversee the implementation of the stoppage came to us as a shock. It is an HMO official who is stating this. The stoppage came to us as a shock, but the issue of funding and corruption led to the stoppage with a rebounding effect on the people in the communities because they were dissatisfied. Corruption on the part of the government because there was an agreement to pay counterpart fund. That means meaning that the government they defaulted in paying the counterpart fund for running the program. However, also on the part of the health maintenance organization, another staff of the HMO noted that I also feel that maybe some people were a bit extravagant. When you see the Dutch people funding the program coming to Kwara, they would not use aeroplanes, but let the Nigeria people come from Lagos to Kwara. They came in aeroplane. It means that the leadership, the resources that was available at that time was not effectively managed. They felt they could be spending. There was no effective management. There was no accountability measures in place in order to curtail and actually outline the procedures for financial engagement. They were just spending the money the way they liked at the time. Meanwhile, there was also a silence on the part of the government, the government officials who were also part of the implementation of the program. They were seeing all these excesses, but because they were doing something wrong, and the other partner, the health maintenance agency officials were also doing something wrong, so they were not challenging each other, and this also contributed to the collapse of the program. The next slide, please. As a result of all of these challenges, the people, unfortunately, have been taken back to the experiences that they were having in the pre-2007 period, where they were having difficulties in accessing healthcare within their vicinity and at an affordable price. That is the consequences of all the actions that these people were taking, which was not in the interest of the people. Then to round up, the main lessons from the study is that North-South social protection policy transfers and policy failure. Most of these policy options that that are being prescribed for the global South are not sensitive enough to tackle the challenges that we face. And this is one of them. The point is that the policy was not homegrown. It was not designed based on the reality of the people on ground and the socio-economic context of this environment. And it is one of the factors why the program failed. Then the second thing is that there was weak institution in place. The institution was weak because there should be accountability mechanisms in place. in order for people to, there should be operational guidelines to guide people, and there should be checks and balances to ensure that people are actually doing what is expected of them. So when situations are not designed like this, what is bound to happen is policy failure. Then third, short-term policy and temporary goals means that when you, the community-based health insurance program was prescribed as a policy in order to ensure that access to healthcare is not a challenge to people. But in the long run, it is not an holistic or comprehensive model of healthcare system that could actually bring access to healthcare for everybody. Because even the premium that enrollees in the program were expected to pay was not an amount, though it was highly subsidized and it was not much, but it was not something that could be affordable, that was affordable to everyone. So when we are always paying attention to short-term policies, then we should also expect temporary results from policies like that. Then the way forward to attaining universal healthcare coverage is repurposing the role of the states to be more responsive and responsible for the people by designing and implementing long-term and formidable social and healthcare policies for meaningful and transformative development. Thank you for your attention.
Thank you very much, Hafiz, for joining us today.
You are welcome.
A lot. So I have a question for you. How do you see the future of health policy, but in particular social policy post-COVID in Nigeria?
Well, okay, I'm listening.
What are the main reform? Do you think we should rethink centralization of social policy, or giving more or empower more states? How do you see the future of social policy?
Sorry, you said, do I think we should do what or what, please? There was
what should be done? What should be done in post-COVID in relation to social policy?
Okay, well, for me, the current experience of COVID-19 is a wake-up call for all of us in the global South and also globally, but most especially for nations in the global South. In order to, there is a need to engage in transformative, what we call transformative social policies. We should not continue to settle for these makeshift social policy prescriptions that would not have an overarching effect on the present and the future. For instance, though from the Nigerian perspective or from the Nigerian experience, Nigeria is lucky to the extent that there were no so much cases of COVID-19 in Nigeria as we speak. But the experience of South Africa is more unfortunate. There are more than 1 million cases of COVID-19 in South Africa, but we have weak healthcare system and we have poor social policies. Do you understand? Well, it may be arguable to state that the government cannot continue to provide for people, but there are some social services that the government is supposed to play more active role rather than being a moderator or a manager of affairs within the sector. For instance, the healthcare system. The situation of the COVID-19 pandemic is not, it gives us an understanding that you cannot live the healthcare, the government has to take leadership to a large extent, especially in the interest of majority of the people. And the same thing applies to the education sector, pension, and some other sectors in the society. Thank you.
Thank you very much, Hafiz, for your presentation and
You're welcome.
your chapter. I think we should stop here. Thank you again, Hafiz, and thank you, Rabia, for joining us. And,
Thank you very much.
please,
You're welcome.
and we'll be in touch regarding the chapter.